Welcome to the deep dive. Today, we're taking a look at some revision notes focused specifically on tremors.
Right.
Our plan is basically to break these down, pull out the really high yield stuff, the core knowledge you need to feel confident about this topic.
Exactly. Tremors, they seem simple, but they can point to so many different things. Getting clear on the basics from these notes is definitely key.
For sure. So for you listening, if you want to get the essential info on tremors quickly but properly, that's what we're here for. We'll go through what they are, the causes, how they look, diagnosis, management, the whole lot based strictly on these notes.
Yep. Sticking to the source material, making it clear and hopefully memorable.
Okay, let's jump in. First things first, according to these notes, what is a tremor? The basic definition.
The source keeps it simple. It's an involuntary rhythmic shaking. That's the core. But crucially, it adds that it can happen either at rest or during movement.
Okay, involuntary rhythmic shaking.
Yeah.
And the rest versus movement part sounds important.
It really is. It's one of the first big clues.
So the notes must break that down further, right, into different types based on when they appear.
Absolutely. This classification is fundamental. The notes list three main types. First, rest tremors.
Okay.
These pop up when the body part is completely supported, like hands in your lap. And the notes immediately link this type specifically to Parkinson's disease.
Got it. Rest tremor equals think Parkinson's, according to this source. What's next?
Then you've got postural tremors. These appear when you're holding position against gravity. Think holding your arms stretched out.
Right, like holding a posture.
Exactly. The notes mention things like physiological tremor, which we all have to some degree, plus drug-related tremors and familial tremors often fit here.
Okay. And the third type?
Kinetic tremors. These happen during active voluntary movement, and the notes specifically highlight intention tremor as a type of kinetic tremor.
Contention tremor.
Yeah, and that one's a big flag, according to the notes, suggesting potential issues with the cerebellum, the part of the brain handling coordination.
That's a really clear framework then. Rest, postural, kinetic. Parkinson's, maybe ET or physiological or cerebellar issues.
Yeah.
Nice. The notes also add that, tremors can signal underlying disease and that essential tremor is common, but, quote, not always benign.
Mm-hmm. That's an important point they make early on. Common doesn't mean insignificant.
Definitely something to keep in mind. Okay, let's dig into the why. What actually causes these tremors? The notes seem to list quite a few possibilities.
They do. It's a broad range, which is why that typing is so helpful initially. But yeah, causes. Okay, so first up, highlighted as common is essential tremor, or ET, often runs in families, tends to worsen with age.
Right.
Then Parkinson's disease, which we've linked to that resting tremor.
Yeah.
Medication-induced tremor. So certain drugs causing it or even stopping some drugs can trigger it. That's worth noting.
Good point. Medication reviews are key.
Definitely. Then cerebellar tremor, linking back to those intention tremors and cerebellar damage.
Okay.
And physiological tremor. The notes explain this as like a normal fine shaking everyone has. But it can get exaggerated.
Exaggerated by what?
Things like illness, fever, stress, anxiety, maybe hyperthyroidism, caffeine, certain meds. Loads of things can amplify it.
So the baseline tremor gets more noticeable.
Exactly. Then the list goes on. Post-traumatic or after neurosurgery, other movement disorders. The notes mention things like multiple sclerosis, other types of Parkinsonism, dystonias, tardive dyskinesia, even cerebrovascular disease like stroke.
Wow.
Yeah, also metabolic problems, electrolyte imbalances, kidney or liver failure. Structural issues like Wilson's disease, which is about copper buildup, or lesions in the basal ganglia.
Okay.
Psychogenic tremors are mentioned too, linked to mental health. The notes say they can worsen with stress, but interestingly, improve with distraction.
That's a useful clinical clue.
It is. And finally, the notes list poisoning arsenic, heavy metals, and even vitamin B1 deficiency.
That list really drives home that tremor is just the symptom, right? The detective work is figuring out which of these many paths led to it.
Precisely. It underscores the need for a careful approach.
So given that huge list, are there things that put someone more at risk? What risk factors do the notes highlight?
The notes list a few general ones, bearing in mind it varies by cause. Family history is a big one, especially for essential tremor.
Makes sense if it runs in families.
Yep. Age tremors are just generally more common if people get older. Medications, as we saw, are a direct risk factor.
Right.
And having underlying neurological conditions like Parkinson's obviously increases the risk for that specific type of tremor.
So pretty straightforward factors, but crucial for history taking. Family, age, meds, other conditions.
Exactly. Helps narrow things down.
Now, this is always a fascinating bit for me. The how. How does this shaking actually work at a biological level? What's the pathophysiology in these notes?
The notes give a pretty concise explanation. They say the root cause is abnormal oscillations, like rhythmic firing of nerve signals within the brain's motor circuits.
Oscillations, like a faulty rhythm in the movement control system.
That's a good way to put it. These abnormal signals cause the muscles to contract rhythmically, and that's what we see as the tremor.
Okay.
And importantly, the notes add that the specific brain areas and circuits involved differ depending on the type of tremor. So the wiring fault is in a different place for a Parkinson's rest tremor compared to an essential tremor's postural tremor.
Ah, so the where determines the when and how of the tremor. That links the physiology to the clinical types neatly.
Exactly. It's all about disrupted rhythmic signals in those motor pathways.
Okay. Now, sometimes things can look like a tremor but aren't quite the same. What about differential diagnosis? What else might be considered, according to the notes?
Yeah, good point. The notes mentioned a few conditions to keep in mind, things that need to be differentiated. Parkinson's disease and essential tremor are actually listed here too.
Wait, weren't they causes?
They are, but the point here is differentiating between them or distinguishing the tremor from other features of the condition or from other potential causes. It's about diagnostic clarity.
Okay, got it. Distinguishing within the tremor world. What else?
Dystonia, those involuntary muscle contractions causing twisting postures, can sometimes look a bit like tremor. And Wilson's disease is mentioned again, as it has other signs that help distinguish it.
So it's about being sure it is a tremor pattern and not something else, and then figuring out the specific type or cause of tremor.
Precisely. The notes stress it's complex and needs careful evaluation.
Let's talk numbers. How common is this? What does the epidemiology section of the notes say?
Well, they say getting an overall figure is tough because of all the types, giving a wide range from 0.4% up to maybe 6% of the population affected by some kind of tremor.
That's quite a range.
It is. But the really standout number is for essential tremor, ET. The notes estimate ET affects around 4.6% of people.
Wow, nearly 1 in 20. That's much more common than I might have guessed.
It is surprisingly common. Compare that to Parkinson's tremor, which the notes put at about 1% of people over 60.
Okay. Any other key stats?
They mentioned equal gender distribution overall. And for ET specifically, about half the cases are familial, passed down in an autosomal dominant pattern.
Meaning a 50% chance for offspring if a parent has it.
Exactly. And onset, various familial cases might start younger, even childhood, while sporadic cases often pop up after 40.
So ET, very common, often familial, autosomal dominant, variable onset age. Key points there.
Definitely the high-yield epidemiology for
It's like, let's get practical. Clinical features. If you're seeing someone, what does a tremor actually look like? How does it present?
So the general description is that involuntary shaking, variable amplitude, how big the shake is, and frequency, how fast it is, often measured in hertz, and again, rest or activity.
Okay, the basics. But what about specifics for the main types?
Yeah, the notes detail these. Essential tremor, ET, typically presents as a postural tremor, remember, holding against gravity, usually distal, so hands mainly, and symmetrical both sides. The notes specify low amplitude but rapid frequency, giving a range of 8-10 hertz.
8-10 hertz, okay.
It can also hit the neck, face, voice, key clinical points. It tends to progress over time, and here's that interesting bit. It can often be improved by concentration or a bit of alcohol.
The alcohol effect is classic for ET, isn't it?
It's a very well-known feature, mentioned clearly in the notes. They also say it's frequently confused with other types.
Got it. What about physiological tremor?
They're described as that normal, fine shake, maybe exaggerated by anxiety, fever, meds. It's linked to posture, bilateral, symmetrical, and crucially non-progressive. It doesn't worsen over time itself.
Okay. And secondary tremors?
The presentation really depends on the underlying neurological disease. They usually come with other signs specific to that condition.
Right, look for the whole picture. And psychogenic?
Key features from the notes. Often abrupt onset, the characteristics might change, and that really important point, distraction, alleviates the tremor.
That ET versus psychogenic distinction, improvement with concentration alcohol versus improvement with distraction, feels like a really useful takeaway from these notes.
Absolutely. Those are powerful clinical differentiators mentioned.
The notes also mention reviewing meds, looking for hard neurosigns on exam, checking gait, cerebellar function. All makes sense for finding the cause.
Yep. The exam is crucial for clues.
So you've done the history, the exam.
Huh.
How do you confirm the cause? What investigations do the notes recommend?
The big emphasis in the notes is that diagnosis is primarily clinical. based on that thorough history and neurological exam.
So tests aren't always needed.
Not necessarily expensive ones, especially if the picture clearly fixed something like typical ET or physiological tremor. But investigations are used to look for those underlying causes, if suspected.
Like what?
Imaging, like an MRI, if you're worried about a structural brain issue, a lesion, stroke damage, thinking cerebellar or basal ganglia
Makes
causes.
sense.
Lab tests for systemic causes. The notes list UNEs for kidney function electrolytes, LFTs for liver function, FBC, the basic bloods.
Standard workup.
Yeah. And specifically TFTs if hyperthyroidism is on the list, maybe for exaggerated physiological tremor, and copper-caroloplasmin if Wilson's disease is a possibility.
Specific tests for specific suspicions.
Exactly. And they advise considering CT-MRI or neuro referral if CNS disease is strongly suspected. But again, the key point is targeted investigation based on clinical findings, not a scattergun approach, especially for suspected ET or physiological tremor unless they're atypical.
That's very practical advice. History and exam first, then targeted tests if needed.
That's the message from the notes.
Okay, diagnosis sorted. How about management? Once you know the cause, what do the notes say about treatment?
It varies a lot depending on the cause, naturally. But the notes give some general approaches. Medications are common. Beta blockers, anticonvulsants, sometimes benzodiazepines can help reduce the shaking.
Right.
For more severe refractory cases, deep brain stimulation, DBS, is mentioned that surgical option with implanted electrodes.
The brain pacemaker idea.
Sort of, yeah. Modulating those faulty signals. And occupational therapy is highlighted for practical help strategies, adaptive devices, managing daily life with tremor.
Okay. What about for ET specifically? The notes seem to detail that.
They do, based on severity. For mild ET, often no treatment. For mild to moderate, maybe intermittent therapy, like taking meds only when needed.
Okay.
For persistent disability, then continuous therapy. Meds like propranolol, a beta blocker, and primidone, an anticonvulsant, are noted as effective first-line options, though they do mention side effects and say evidence for other meds is limited.
Propranolol and primidone for ET.
Got it. Botulinum toxin A gets a mention for a head tremor specifically. DBS is described as well accepted for severe ET. And MR-guided focused ultrasound is noted as promising, but still with limited evidence, according to these notes.
So a stepped approach for ET. What about physiological?
Usually no active drug treatment needed. But if anxiety is a big driver, maybe CBT or antidepressants could help address that underlying factor.
Makes sense. And for secondary tremors?
The main thing is treat the underlying parent disease. If it's tremor from Parkinson's, treat the Parkinson's. If it's from hyperthyroidism, treat that.
Address the root cause.
Exactly. And the notes re-emphasize checking current meds first. Could they be the cause? Try reducing the dose before adding a new tremor drug.
Always review the meds. Good clinical pearl.
Absolutely fundamental.
Lastly, the long view. Prognosis and complications. What do the notes say about the future for someone with tremor?
Highly variable. Depends entirely on the cause. The notes state essential tremor persists, doesn't go away on its own. Parkinson's tremors might worsen as the disease progresses.
Okay. And complications.
Mostly functional and quality of life impacts. Limitations in daily activities, the emotional burden, overall reduced quality of life. Some people can become severely disabled by their tremor.
So it can be really debilitating.
It definitely can be. For essential tremor specifically, the notes actually label it as neurodegenerative.
Neurodegenerative. That sounds serious.
It does. They mention factors affecting progression, like asymmetry and age of onset, with earlier onset maybe progressing slower. They estimate an annual severity increase between about 3 and 5%. And the notes state pretty clearly, there's no cure for ET mentioned here, and it doesn't slow down spontaneously.
Wow. So ET isn't benign, it's progressive, neurodegenerative, and can significantly impact life with no cure outlined in this source. That really reframes it.
It does. It highlights the importance of taking it seriously. Physiological tremor, though, is usually non-progressive. Tremors from CNS disease follow the course of that underlying disease. And drug-induced tremors might persist even after stopping the drug, unfortunately.
Okay, that covers the long term. We've been through a lot of detail from these notes. Let's try and boil it down. What are the absolute must-remember high-yield takeaways?
All right, top takeaways from these notes. First, the types. Rest tremor, think Parkinson's. Postural kinetic, think ET, physiological, cerebellar. That distinction is key. Second, essential tremor. Most common, often familial, autosomal dominant, worsens with age, classically improves with alcohol concentration. Remember, 8-10 Hz frequency. Third, psychogenic tremor. Key feature is improvement with distraction.
Heavily reliant on history and exam first. Investigations are targeted based on clinical suspicion, e.g. TFTs for thyroid, copper for Wilson's.
Tailored to cause. Mild ET often needs no treatment. Propranolol are first-line meds for moderate to severe ET. DBS is an option for severe cases. Secondary tremors need treatment of the underlying cause. Always review meds.
Variable. ET is described here as persistent, progressive, and neurodegenerative with no cure mentioned, impacting quality of life. Physiological is non-progressive. Others depend on the cause.
That's a fantastic summary. Really hits the core points from the notes. Rest versus action, ET features, psychogenic clues, clinical focus for diagnosis, tailored management, and the progressive nature of ET.
Those are definitely the highlights to retain.
Okay, before we wrap up, time for that final provocative thought, building on what we've learned from the notes.
All right. Given that these notes describe essential tremor as neurodegenerative and progressively worsening, with no cure mention, where should the main focus of future research lie? Should it be primarily on developing better ways to manage the symptoms and improve daily function? Or should the priority be on understanding and tackling the underlying neurodegeneration itself, aiming to halt or even reverse the disease process?
Symptom control versus tackling the root cause. A really important question for the future of ET research. Definitely something to think about. And that brings us to the end of this deep dive into the tremor revision notes. We've unpacked the source material, hitting the definitions, causes, risks, the how, the what else, who gets it, how it presents, investigations, management, and the prognosis.
Hopefully, breaking it down like this helps solidify the key information for anyone revising this topic.
Exactly. Getting these fundamentals down is crucial. And if you found these notes useful, you might want to check out pastthemfsra.com and freemsra.com for more revision resources.
Good resources to know about.
Definitely. Keep diving deep into the topics you need to master. Thanks for joining us, and we'll see you on the next deep dive.